Welcome and thank you for joining us for the Psychosocial and Ethics Community of Practice Ethics webinar on COVID-19 vaccination. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. On your screen, you will see a poll. Please take a moment to answer this while we finish the remaining announcements. This webinar is being recorded and the archive will be available on the Psychosocial and Ethics COP Hub next week. Please note that all of your lines have been muted so that only the presenters can be heard for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the questions section in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. If there are questions we don't have time for, we will either answer them individually offline or we will post the full question and answer on the Hub following the webinar. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to one of our organizers of the webinar. Thank you.
Welcome to today's webinar. I'm Carrie Thiessen, a member of the Executive Committee of the Psychosocial and Ethics Community of Practice. On behalf of our COP and the AST, I'm delighted to welcome you to today's webinar, Ethical Considerations in COVID Vaccination for Organ Transplant Candidates, Recipients, Living Donors, and Caretakers. I would like to acknowledge the efforts of the AST team and the AST COVID Task Force, which helped to approve the webinar in record time in response to the needs of many transplant centers that are currently debating their COVID vaccination policies. I extend a warm thanks to our excellent lineup of expert panelists and our moderator. We're going to keep our Q&A to the end, and I encourage everyone to participate in the discussion. In the interest of time, each panelist will briefly introduce themselves. Dr. Diekema, will you please start us off? Thank you.
Thank you, Carrie. It's my pleasure to moderate this webinar on ethical considerations related to COVID vaccination of organ transplant candidates, recipients, donors, and caretakers. I have no relevant financial relationships to disclose, and I will not be discussing any off-label uses today. What we hope to address in this webinar is a number of questions, including whether it's ethically permissible to mandate COVID vaccination for waitlisted transplant candidates, whether living donors should be required to be vaccinated prior to donation, and when, if ever, should vaccine mandates be required for caretakers. And to help us address this question, we have a wonderful panel that includes these four individuals, all of whom are experts in relevant areas, and they are going to help us address these questions today. Starting off, Olivia Kates, I'm going to turn it over to you.
Thanks, Doug. All right. I'm Olivia Kates. I'm an assistant professor of medicine and infectious diseases at Johns Hopkins, and I'm getting us started with some data to inform vaccination policies. These are my limited disclosures, and this is our agenda. So we'll start on the wait list. First, COVID-19 incidence in unvaccinated waitlist candidates has been higher than in both transplant recipients and the general population. And this population-based study from the UK, which was published in the pre-vaccine, pre-treatment era, found a case fatality rate of 10% among waitlist candidates with COVID-19. I'd guess that a mortality estimate would be lower now with better treatments, a more prepared healthcare infrastructure, at least in many places, and more widespread testing picking up milder cases. But essentially, the people at the starting point of this debate are unvaccinated candidates already face high COVID-19 incidence and probably at least moderate mortality. Now, if those candidates get transplanted, they'll still have a higher COVID-19 incidence than the general population. In studies from the pre-vaccine but now early treatment era with widespread use of treatments like remdesivir and dexamethasone, we see mortality rates of 8 to 13% among all comers, whereas we previously quoted statistics closer to 20% mortality. I'll note that mortality is higher in lung transplant recipients. And mortality is not the only outcome of importance. Transplant recipients have a lot of morbidity after COVID-19 too. For kidney recipients, for example, 8 to 19% have residual allograft dysfunction, and 1.5 to 7% have graft loss. And now we're going to talk about vaccine effectiveness, but most of the data I'll present are just surrogate indicators for protection from the vaccine. And the word immunity is really a shorthand for a very complicated topic. So humoral immunity is the easiest thing to measure. These are antibodies against SARS-CoV-2 spike protein. Neutralizing antibodies are harder to measure directly. These are antibodies that disrupt viral replication when added to viral culture, although some studies have used surrogates like antibodies that specifically interfere with binding ACE2. And then finally, cellular immunity refers to T lymphocytes that recognize SARS-CoV-2 antigens. And what we want most are clinical indicators of vaccine effectiveness, like reduction in infections, hospitalizations, or mortality. But when that information isn't available, these other tests can give us some idea of what's going on, and usually more quickly. So transplant recipients who get vaccinated against COVID-19 have an attenuated immune response. After 2 doses of mRNA vaccines, around half of transplant recipients will have evidence of humoral immunity, fewer will have evidence of neutralizing immunity, and half will have evidence of cellular immunity. In one study, the breakthrough infection rate was 0.4% over an average period of 2 months, and mortality from breakthrough infections in patients vaccinated after transplant so far seems to be 8 or 9%. All of these indicators of immunity fall short of what's seen in the general population, where humoral, neutralizing, and cellular immunity are seen in nearly all vaccinees, and mortality from breakthrough infections is less than 1%. A 3rd dose of an mRNA vaccine is associated with improvement in humoral, neutralizing, and cellular immunity. We don't yet have good data on the clinical impact of 3rd doses. And as much as I've tried to simplify and summarize those data, there are a lot of caveats. So vaccine immunogenicity is worse for recent transplants compared to remote transplants, worse for lung and kidney recipients compared to heart and liver, and worse for patients taking belatacept or any antimetabolite containing immunosuppression. Vaccine response is augmented in patients with prior COVID-19, and mix and match vaccination seems to be better than 2 doses of viral vectored vaccines, but it isn't necessarily a big improvement upon an mRNA vaccine series. So with high risk and devastating COVID-19 outcomes in unvaccinated transplant recipients, an attenuated response to vaccines after transplant, and then similarly poor outcomes in breakthrough cases, we've come to this, which is the push for vaccination to happen before transplant. So looking at hemodialysis patients as a surrogate for many transplant candidates, even if their responses are less than healthy controls, most dialysis patients will have evidence of a humoral response to vaccination, and many, more than half, will have neutralizing antibodies and cellular immunity. They may have a breakthrough infection rate of around 3.2% in an average of 10 weeks, although I'm extracting those data from a small study that wasn't designed to measure this outcome. And then in a study of vaccinated liver transplant candidates, most had evidence of humoral immunity. The next question is whether pre-transplant immunity continues to protect patients after transplant. In one small series of 8 patients who underwent kidney transplants after vaccination, all 8 maintained their anti-spike antibody titers at similar levels to pre-transplant. In another study, the authors didn't measure immunity before and after transplant, but looked at patients after transplant and found that if the patient had been vaccinated before transplant, they were more likely to have anti-spike antibodies at a higher titer than patients who weren't vaccinated until after their transplant. So unvaccinated candidates begin at this starting point on the wait list, where they face high COVID-19 incidence and probably moderate mortality, although that figure 10% comes from the pre-treatment era. If candidates are vaccinated first while on the waiting list, most will have markers of humoral immunity, and many will achieve neutralizing and cellular immunity. Dialysis patients specifically may still have a lot of breakthrough infections, but I would guess that this is an overestimate of the breakthrough rate for all vaccinated candidates, in part because of frequent exposures from dialysis centers and shared or public transportation. So this may be a worst case scenario. If vaccinated candidates get a transplant, most, or really all, seem to retain that evidence of humoral immunity, but all these other data points are still under investigation. If candidates go straight to transplant, on average, they may have a lower infection rate than unvaccinated folks left on the wait list, but they face high mortality, even despite early treatments like remdesivir and dexamethasone. And all of these risks may be magnified, especially in the early post-transplant period, so these estimates may reflect more of a best-case scenario. If previously unvaccinated recipients go on to get vaccinated, many will achieve humoral immunity, about half will have neutralizing antibodies, and most will have cellular immunity. Their average breakthrough infection rate seems to be 0.4%, but mortality from breakthrough infections is still high at 8 or 9%. And of course, candidates who refused vaccination pre-transplant may continue to refuse after, and they'll stay in the unvaccinated box. Even if they eventually choose to be vaccinated, achieving full protection from a 3-dose series takes time, and vaccine immunogenicity is worse in the early post-transplant period. So this last box is also something of a best case scenario. And there may be an impact beyond the candidates themselves. And so in this report, a kidney transplant recipient with prolonged SARS-CoV-2 shedding accumulated multiple viral mutations, including mutations in the virus isolated on day 105, a long period. I've circled that example, that helped the virus escape neutralizing antibodies from both convalescent and vaccinated sera. And so the authors of this report proposed that immunosuppressed patients with SARS-CoV-2 may become a point of origin for novel variants with potentially global implications. And then even without creating new variants, immunosuppressed patients with prolonged shedding may be more likely to transmit SARS-CoV-2 to others, including to fellow patients and staff. So I hope these data were helpful. I'm going to hand the presentation over to Dr. Adey.
Good afternoon. Let me share my screen. I'm Dr. Deborah Adey. I am a I'm a transplant nephrologist, medical director of kidney transplantation at UCSF. And I'm going to give you a presentation of 3 different scenarios, which will reflect what Dr. Kates just talked about. So my disclosures, I have some advisory consulting resources from Otsuka and Natero, none of which is relevant to this, editorial board, and several committee memberships. None of this is financially relevant to what I'm talking about. So a little background on our program. We are a little bit of an outlier in that we have 4,500 patients on our wait list for transplantation. We performed 414 kidney transplants last year, of which about 250 were deceased donor and the remainder being living donors. So I'm going to give you a case scenario. This is the first case. Patient is called in for a kidney transplant. He's not vaccinated, nor is his family. He's a 31-year-old male, end-stage renal disease secondary to IgA nephropathy. He's been waitlisted since January of 2016 with a low PRA of 8%. He lives 4 to 5 hours away from UCSF. He had COVID in February of 2021, recovered, but when he was called in for a transplant in September of 2021, he was still positive for COVID. So that kidney was declined. Now it is 2 months later and he's brought back in. He's now negative for COVID by PCR. And he's getting a kidney that's a very good kidney. It's a deceased donor. However, the donor was COVID positive as of just a few days prior on 10/31, cycle time of 16.4. It's a DCD donor with a KDPI of 2%. So this is a very good kidney for him. So the dilemma is that this is a COVID positive donor in a patient who has not been immunized yet against COVID. He was scheduled to get his COVID vaccine the week after he was called in for his transplant. So this is one case scenario. So what did we do? We gave an infusion of monoclonal antibodies on the day of transplant. We checked PCR, it was negative. We're still pending the outside PCR. Recommend COVID-19 vaccine after starting 90 days after his monoclonal antibodies. But what's the problem here is that one, he cannot come to clinic for follow-up because of the COVID. This limits his wound check, it limits his education. Fortunately, he is technologically savvy enough to do video visits, but there is some advantage to having patients in clinic shortly after transplant. He also cannot go to the lab for lab draws, so we had to arrange for home healthcare services just to get his blood work done. The next case is a patient who's vaccinated, but the designated care provider is not. This is a 67-year-old gentleman called in, set up for a preemptive transplant. He's Thai speaking. He was through an exchange. He was admitted for his preemptive living unrelated kidney transplant through NKR in August. He'd had 2 doses of the COVID vaccine, had an uneventful surgery, creatinine 1.07, the post-op day 2, down from about 8 on the day of surgery. Looks great, ready to go home, only to find out that the caregiver got exposed to COVID the day prior to discharge. So this sets us up for a problem is he's ready for discharge. He has a creatinine on post-op day 3, which is our typical post-discharge day. A creatinine 0.87. He lives with multiple family members, one of which is his care provider, who has not been vaccinated, now has a COVID positive exposure. They do not have a lot of resources. We're not able to discharge the patient because he has nowhere else to go. And it added 2 days to his hospitalization just to wait for the COVID tests to come back negative. Our last case is a challenging case. It's a 48-year-old woman who's HIV positive, diabetic, transplanted in 2018 before the onset of COVID, had great kidney function, creatinine of 0.86, did all the right things, got her Moderna vaccine. She's had 3 doses, 9/13 was her last dose. In September, she was treated for recurrent glomerulonephritis, pyelo, collapsing FSGS, some interstitial nephritis, some ACR, treated with a PO dose of steroids, so at a dose of about 2 milligrams per kilogram. And then the next month admitted with COVID in October of 2021 with a creatinine of 9.0, and her exposure being she lives with her sister who had refused vaccine. So current status, she's been treated with remdesivir and dexamethasone. She remains in the hospital. As of 48 hours ago, she was still intubated on FiO2 of 80%, sedated on CVVHD, and still requiring pressors. So the issues here is she did everything right, but the impact of her family members not being vaccinated who live with her has had a devastating impact here. So we don't need that. So at this point, those are the presentation of the cases, which will provide a foundation for some discussion. Because I am a transplant nephrologist, I don't have other organ transplant availability. So at this point, I'm going to turn it over to Dr. Rebecca Madan, and she can take it from there, and I will stop sharing.
Hi, everyone. I'm going to go ahead and share my screen. Good afternoon. My name is Rebecca Madan. I direct the Pediatric Transplant Infectious Diseases Program at the NYU School of Medicine in New York City. And today I'm going to talk about some of the lessons we learned about pediatric vaccine hesitancy in vulnerable populations following the 2018 measles outbreak in New York City. And I have no financial disclosures. So measles was declared eradicated in the United States in 2000, but starting in about 2010, we had declining vaccine rates in very specific populations in New York City. And in September or November of 2018, an unvaccinated child traveled from Israel to Brooklyn just after the Jewish high holidays. And this child, who was unvaccinated, contracted measles in Israel, and measles was subsequently disseminated through a very specific community in Brooklyn. Over the next year, we had almost 700 cases of measles in New York City, and the outbreak took about a year to get under control. So we had our last case of measles in the summer of 2019, and the outbreak was finally declared over in September 2019. Not surprisingly, children were the most vulnerable. The mean age at diagnosis was 3 years. About 7% of children who were diagnosed with measles were admitted to the hospital. Several of these children ended up in our ICU here at NYU and on our general pediatric units. And not surprisingly, over 85% of cases were unvaccinated. And what's interesting about this epidemic in New York City is that the cases were concentrated in a very small number of zip codes that are specific to the Williamsburg neighborhood of Brooklyn, which is actually where I live, as well as Borough Park, Brooklyn. And that is because the epidemic occurred primarily among the Satmar sect of Hasidic Jews who live within very narrow neighborhoods of Williamsburg and Borough Park. Over $8 million were spent to administer over 33,000 doses of MMR vaccine to get this outbreak under control. And ultimately, the New York State public health laws were amended to disallow religious and personal belief vaccine exemptions for children. So essentially in New York State, no child can attend any licensed daycare, pre-K, early education, elementary or secondary school without getting vaccinated unless they have a very clear documented medical exemption. And there were numerous legal challenges to the amending of the public health law, but fortunately the law was upheld with the state of New York Supreme Court ruling that elimination of religious objections to child vaccination, quote, is in the best interest of public health, particularly for children. And at NYU, when we went back and looked at all of the children that we had tested for measles during this year-long outbreak, we found that even a year after the outbreak, over a quarter of the children that we had tested were still unvaccinated. Even if you get measles, you need to eventually get MMR to make sure that you don't get mumps or rubella. And we've had numerous mumps outbreaks, particularly in the Hasidic community in the past 20 years. But what we found was that despite our best efforts and despite our outreach, a large population of vulnerable children remained unvaccinated. So how did this happen? And how do we promote the safety and efficacy of childhood vaccines in marginalized communities? So in understanding why this happened, it's important to keep in mind that there is no Jewish prescription against vaccination. In particular, there's nothing even within the Satmar Hasidic sect that specifically argues against vaccination. But the Satmar Hasidic community was essentially decimated during the Holocaust. The few remaining members of the community came to the United States, reestablished their community in Brooklyn, and they remain highly traumatized by the Holocaust. That memory is very much alive in their community, and it contributes to a significant mistrust of government agencies and to really any secular authority. And as we have seen happen in other marginalized communities across the United States, there were anonymous groups that started to distribute written information throughout the Satmar community, scaring parents about vaccines and really playing upon their mistrust of government and secular agencies. And this was just one significant factor that contributed to a decline in vaccination in this community over the past 10 years, and it has persisted as a barrier to vaccination in this community. So there are fortunately leaders in this community, such as Blima Marcus, who is, she is Orthodox. She is also an oncology nurse at Memorial Sloan Kettering, and she has come together with her colleagues to combat vaccine hesitancy in her own community through a lot of education. But her approach is one that is very much non-judgmental, that is empathetic, and she really urges us to keep in mind the trauma that this community bears when we talk to families about the need for vaccination. And I think to a certain degree, this also applies to vaccine hesitancy in communities that have really been disproportionately impacted by the COVID-19 pandemic. Dr. Phil Ozawa, who is the president and chief executive for Montefiore Medical Center in the Bronx. Over 2,000 patients died at Montefiore just in the first 12 weeks of the pandemic in New York City. And Dr. Ozawa has written and talked extensively about the trauma of the COVID pandemic, how it has impacted patients' willingness to receive the vaccine. And he often refers to 2020 as the year of the twin viruses. The first virus, of course, being the COVID pandemic, and the second virus being the racism that is endemic to the United States and that really boiled to the surface during those first few months after the pandemic with the murder of George Floyd and other Black men and women and the subsequent protests. My colleague Suzette Oyeku has also spoken extensively about the need to consider how communities have experienced COVID and have experienced the healthcare system when we talk to families about vaccination. Dr. Oyeku is the chief of academic general pediatrics at Montefiore. She's also an ordained deacon, and she has taken on a tremendous role in vaccine outreach among Black churches in New York City. And when she talks to us about vaccination, and for the reasons why people may be scared about giving the COVID vaccine to their children, she talks a lot about the structural inequity of healthcare, the racism that people may have experienced in the healthcare system, and urges us to keep this in mind when we talk to families, again, in a non-judgmental manner about vaccinating their children. One thing that I also consider is that I often find when I talk to parents in my transplant clinic that they haven't necessarily received accurate information from their own provider about vaccination. I often hear that families have been counseled that they need to wait until their child's eczema has resolved, or that they need to wait until their child stops having ear infections. And we have spent time at NYU reaching out to some of the non-academic pediatric practices that serve underserved communities in New York City. And what these providers tell us is that vaccination is often not a top priority for them. They're not reimbursed to provide counseling. They view enrollment in the Vaccines for Children program as burdensome. In pediatrics, the Vaccine for Children's program is really the bedrock of how we administer vaccines to children, but many providers find that this program is not worth their time. The providers themselves may have an inaccurate understanding of vaccine contraindications. And importantly, there are no incentives for practices to keep children up to date, nor are there penalties for practices that fail to keep children up to date. So what can we do about this in the pediatric transplant clinic? I think that we are uniquely poised as pediatric transplant ID physicians to spend a lot of time with families. I feel it's very important that we meet with families the minute organ failure or transplantation is on the table. We need a chance to build longitudinal relationships with families to gain their trust. It is our job to discuss vaccination status, not just for the patient, but for household contacts at every visit. Particularly at NYU, we now have very restrictive visitation policies, and it's important for families to understand how vaccination may impact their access to the hospital. But I feel that based on what Dr. Oyeku and Blima Marcus and Dr. Ozawa have shared with us, that we really need to approach vaccine hesitancy in families with a non-judgmental approach, with empathy. And I find that it's critical to ask families how they have experienced the COVID-19 pandemic, what trauma have they experienced during the pandemic, and how does this inform their perception of the vaccine? We need to take time to learn families' concerns, and it's also important that we implement hospital-based strategies so that the transplant patient can get vaccinated with us, but we can also offer vaccines to parents and siblings so that we can quickly, efficiently vaccinate the whole family and create a cocoon of protection around the child. That is my last slide. I would like to acknowledge my colleagues, and I have to say, as the pediatrician of the group, I never thought I'd live to see the day when children would be excited to get shots, but we're now seeing our youngest elementary school children, like my 5-year-old daughter, lining up around the block outside of the New York City public schools, ready to get vaccinated. And it's really exciting to see. And with that, I will thank you. I will end my slides and I will turn everything over to Dr. Persad.
Thank you all. I'll go ahead and share my screen because I have slides as well. So I am an assistant professor teaching bioethics and health law at the University of Denver's Sturm College of Law. And I am also a Greenwald Foundation faculty scholar in bioethics. And I'll be talking to you today about primarily ethical and legal considerations related to transplant allocation, although some of them will also relate to other dimensions of vaccination in the transplant process. A couple of just short disclosures. I'm a ethics and law columnist for actually the American Society for Clinical Oncology's magazine. That's another community that has dealt with a lot of overlap and challenges during the pandemic. And I've received grants and fees not related to this talk from the Greenwald Foundation and from the World Health Organization. I have no financial conflicts related to this talk or its material. So I just wanted to frame first the sort of core challenge in transplant allocation ethics. And that is that it's fundamentally an ethical field that's looking at how to respond to scarcity fairly. And I think all of you who work in transplant are familiar with the fact of transplantable organs being a limited resource. So unlike other areas of medicine where the issue might be framed in terms of patient autonomy or the sort of broad concept of we're concerned about denying people care, here the issue is really going to be how can we fairly allocate a scarce donated resource among potential candidates. And here are 4 ethical values for allocation under scarcity. The first 3 from actually the National Academies of Science, Engineering, and Medicine, their report on vaccine allocation. But I think a lot of these are consonant with transplant allocation ethics as well. So benefiting people and preventing harm, mitigating health inequities, which I would gloss as trying to improve medical outcomes for people who are facing various forms of structural disadvantage, showing equal concern for people, and then reciprocity or recognizing certain sorts of past choices that help to solve or mitigate health problems. So the first value here, benefit and harm. I think there are important ways that these ethical questions really depend on the sorts of research that some of the earlier panelists are doing. So we'd want to know, for instance, to think about whether requiring vaccination for some participant in the process, a candidate or a donor, whether to do that will depend in part from the benefit harm perspective on whether you see an improvement in post-transplant outcomes. You might also look at less direct effects. So if you consider vaccination status, does that increase vaccination rates among your waitlisted candidates, among donors, et cetera, which might create other community benefits? And does it increase or otherwise affect willingness to donate among people who might potentially donate organs? The next value, mitigating health inequities. So the core question here, I think, is going to be, if you consider vaccination status, so say you require vaccination in order to be eligible, or you use it as one among many criteria, you might worry that it could exacerbate or otherwise worsen health inequities. This is again going to depend on a lot of empirical facts. So one thing that's happened over the course of the pandemic is we've actually seen a narrowing or sometimes disappearance of racial disparities over time. So I think between African Americans and white Americans nationwide, it's fairly close, and actually Hispanic and particularly Asian Americans are more vaccinated sometimes than the typically than the average person in the pool. But this does vary state to state, and you'd also need to look at not just disparities in the whole population, but what do disparities look like in your transplant candidate pool with respect to vaccination. Another factor in ethics to look at is that you wouldn't want an outcome that does what ethicists call leveling down, which would you would end up with worse outcomes, actual outcomes for disadvantaged and non-disadvantaged people, but you would reduce sort of disparities on paper. So you wouldn't want to say, well, if we get rid of vaccination status criteria, more disadvantaged people will suffer complications or die, but the outcomes will look more similar, because the goal should be improving outcomes, mitigating inequities by improving outcomes, not by just leveling outcomes of others down. The last point, and there's work elsewhere in COVID-19 ethics on this, really interesting work, is that you could say that you're worried that considering vaccine status would exacerbate inequities. This can be offset by including other criteria, outreach or eligibility, et cetera, that say you have a group that is structurally disadvantaged in some way, that you worry that considering vaccination status would worsen their access. You can offset that by using something like, for instance, social vulnerability indices that basically try to counterbalance that by picking out more people who are vaccinated from those groups that are facing inequities. So there is that possibility, and actually offsetting the potential inequity exacerbation of certain criteria is something that's been done at the nationwide level, something that some of the subcommittees in groups like OPT and UNOS have actually thought quite a bit about. Some of the most thoughtful work on that from even before the pandemic. Equal concern is another value. So the one thing that I think is great in transplant ethics is there's a recognition off the bat that equal concern doesn't require treating everyone the same. So there are all sorts of factors that are used to differentiate candidates. The question is really which are appropriate factors to consider. One factor that might be relevant, although it doesn't settle the question, is that not being vaccinated compared to other things that might be factors for transplant loss or complications is much more often something that is easily reversible by being vaccinated, and also much more often the result of a near-term immediate choice than other factors that might create need. Last value is reciprocity. So we might think if we consider vaccination status, this also might be justified as a recognizing past choices to protect others. So we do this elsewhere in transplant ethics, for instance, sometimes prioritizing past donors, or especially in other countries, prioritizing those who have promised to donate, and then also reciprocity toward the donors themselves by responsibly stewarding a donated resource. So if we promise donors that they're donating life, we may have a responsibility to then steward what they're donating in a way that actually saves lives. So the second bullet point will, of course, then depend on whether a given consideration of vaccination status does lead to better outcomes, and so does a better job of keeping our promise that you're donating life. Potential legal issues. So I'll make a couple brief comments about this. The first is, you might think, there's an obligation in general to reasonably accommodate if people have medical conditions or certain religious exemptions, but you're not required to ignore medically relevant differences between candidates. And even in situations, so the first is that not being vaccinated is also different from by choice, is different from not being vaccinated because you're not eligible or because of a religious objection. And particularly in the religious case, not all accommodations are going to be reasonable. So if you, some centers won't transplant people who refuse transfusion, and that's not viewed as unreasonable or discriminatory by those centers or generally legally. The more specific context is there are a few states, I think Montana is the prime example, that have what we might call vaccine discrimination laws that treat unvaccinated people as almost akin to a legally protected class, like based on race or members of people with a religious belief or with a given disability. I think ethically these laws are troubling because being not vaccinated is not like these other identity criteria for a lot of reasons. But there are some states that nevertheless have adopted those laws, and whether those would impinge on vaccine requirements will depend on the particulars of the law. So some of those laws do exempt healthcare settings because they're kind of implicitly recognized that there really is something important about ensuring that people, say, in healthcare settings are vaccinated. Last couple slides, one is just other issues beyond allocations. So competition for various aspects of hospital capacity, potential overstretching of dialysis needs. I've seen discussion among ethicists of scarcity for ECMO, which might be needed for different procedures, and vaccination for donors. And then for my last slide, what I would really want to stress more than defending a particular approach is to think about what future research we need in this space. So implementation, we want to use vaccination as an exclusion criterion or just as one factor among many. How might we mitigate inequities? So categorized priority systems are one approach where you maybe prioritize a certain set of organs for people who have been vaccinated without necessarily having it as an exclusion criterion where nobody who's unvaccinated has access. Other areas for empirical research, donor, recipient, public perceptions of different policies, empirical modeling. So how many more lives look like they would be saved under different approaches to considering vaccination. Just caution against what psychologists call proportion dominance. So even if something only saves, in expectation, 10 lives out of 10 or 10, 1,000 or 10,000, that's still 10 lives saved, which I think is still equally important regardless of what denominator it comes out of. And then last are the legal issues that I mentioned. So I'll stop here, and I really look forward to the moderator of the audience's questions.
Well, thank you to our 4 panelists for very thought-provoking presentations. For our audience members, this is your opportunity to engage our panelists, and we would encourage you to type your questions into the question and answer feature, and we will try to take those up. And as we're waiting for people to do that, I'm just going to sort of wrap up by including what I see as some of the major issues here. There clearly are potentially competing ethical obligations when we talk about whether to mandate vaccination for those involved in the transplant arena. We have duties to the patient, him or herself, which are related to beneficence and non-maleficence. We have duties to society because we're talking about a scarce resource that requires some notion of stewardship and justice. And finally, there are patient preferences, and that invokes the notion of respect for autonomy. And these are not always in sync. Most transplant recipients have a need for a caretaker who may have their own interests and concerns and will have their own interests and concerns. And those decisions that caretakers make will impact the welfare of the patient, which was nicely illustrated by one of the 3 cases presented by Dr. Adey. Living donors, the risk of losing potential organs for transplant is an issue, and then there are these issues of equity which we've started to raise and have to be considered carefully when we consider any policy, including one of a vaccine mandate that may disproportionately affect certain groups. Now, the last thing I wanted to say to just sort of throw this into the discussion is that years ago, along with a couple of colleagues, we proposed some criterion that we thought should be met prior to mandating any vaccine antigen for school entry. And what I have done here is modified those criterion for what I think it would look like, the kind of criterion that I think ought to be met before transplant centers mandate COVID vaccination. And those would include that the vaccine has full FDA approval. My personal feeling is if there's not sufficient data for the FDA to fully approve a vaccine, then we probably shouldn't be mandating it. The antigen should be effective as measured by the kinds of things that Olivia mentioned. Experience with the vaccine should indicate that it's safe and has an acceptable range of side effects. The vaccine should prevent a disease with significant morbidity and mortality, which I think most would agree COVID-19 is, and prevent that, at least have some preventative effect in terms of reducing person-to-person transmission. A lot of the concern with regard to caretakers, for example, is their presence in the clinic and potential transmission to others. And if the vaccine doesn't prevent that, then we haven't really solved the problem with a vaccination requirement. The burden of compliance for the vaccine is reasonable for caretakers, and the vaccine requirement does not disproportionately affect certain groups negatively, so that's the equity issue. I think the vaccine should bear some relationship to increasing safety in the transplant environment. And finally, the requirement should not undermine willingness to donate in a significant way. And I think that remains an empirical question. I think we know that there will be some potential donors who refuse to donate if there is a vaccine mandate in place. And I think the only question that really remains is how significant that is and whether it would be balanced by some people being more willing to donate. So that is my proposal. I'm going to stop sharing my screen now, and so that you can see the panelists. And we have some questions in from our audience that I'm going to just jump right in and ask our panelists. The first one is whether lung transplant recipients should be treated differently regarding requirements for vaccination prior to transplant, differently than other organs that might be transplanted, given the poor outcomes for this group and the very poor overall vaccine effectiveness in this group, even as compared to other SOT recipients. So what do you think about that question? Is there something different about getting a lung as opposed to a liver or a kidney? Or
this is Adey. So I can say for our program, heart and lung, we do have a vaccine mandate for recipients to be vaccinated prior to transplant, just like you said, because of the poor outcomes. We have not been able to implement a mandate for liver or kidney. It's been under discussion, but the logistics are a bit of a nightmare. But yes, for heart and lung, we absolutely have a mandated requirement for vaccines.
I think if your mandate is motivated by some of these harms and benefits reasoning that Dr. Persad brought up, then the differential outcomes and immunogenicity from COVID-19 and vaccines in lung transplant patients are a very important consideration. There may not be the same differences in the magnitude of other types of arguments. But yeah, if you're thinking mostly about harms and benefits, I agree. Lung transplant is an exceptional case.
anyone else want to comment on that one? All right, Bob Fine asks a question here and says another way to think about reciprocity is from the vantage point of patient and caretaker duties when seeking a scarce resource from the larger society. What duties does the patient or caretaker take on when seeking utilization of a scarce resource? Is it reasonable to allow a patient and their caretakers to refuse to participate in the larger societal fight against a pandemic while at the same time seeking to prolong the vaccine refuser's life? Thoughts about that?
Well, Doug, go ahead.
I'm happy to say something a little bit about it. Yeah, so I have a lot of sympathy with the idea that there is something inconsistent with, if you think, one way of thinking about justifying a given choice is that you would need to be able to sort of offer that as a rationale to the other people on the waiting list who are also waiting for the scarce organ, and to the person who is has chosen, or their family has chosen, to donate this organ. And there's a spectrum of reasons. So one thing that people worry about with the reciprocity arguments, and I think have different perspectives on, is there are other things that people do that may also sort of create risks of greater resource utilization or not participate in a fight against the pandemic in other ways. What I do think is distinctive about vaccination is that it's something that is changeable in a way that sort of other past conduct isn't, and also accessible. in that way. So I do think the fact of it being alterable and accessible, except in sort of extraordinary cases, and I'm actually interested if folks have run into this example. For the COVID vaccine, I think it is just very, very rare that you have people that have contraindications, but how centers would deal with that. I think if you don't have a kind of medical reason that you can't do it, if it's just that you won't, then I think it does become reasonable to consider at least as one factor, because it does seem hard to justify to the other people on the list who could benefit from that same resource.
I agree. I think that what Dr. Persad has brought up about justifying these choices to other waitlist candidates is really important. Society at large actually doesn't need this resource. Many of us don't need it. The people who need it are the other candidates. And so another reason I think vaccination is a particularly salient example of a reasonable requirement is because it's very transplant specific. This amplified risk is specific to the transplant context. This is something that our transplant providers have expertise and authority in order to make a reasonable judgment about whether it's beneficial versus not. And the other example that I think of when I talk about transplant specificity of these requirements in terms of like pro-social behavior or contributing to the global fight against pandemics or other evils is allocation criteria based on criminal activity. And we do not consider past criminal activity in organ allocation, with the exception sort of endorsed by the Declaration of Istanbul for past criminal activity related to the illegal procurement or transplantation of organs. So as long as we're talking about the transplant specific context, some of these criteria for like participating in social goods seem to be reasonable. And I think vaccination is another example.
Vanita Kumar asks what I think is a very important question, and implicit in the question is also a comment. Do we have a sense of the rate of vaccine refusal in waitlisted patients anywhere in the country? In other words, how prevalent is this problem? And then the important thing she adds here is that my worry about a global vaccine requirement policy, presumably in the transplant arena, is that it would shift clinical practice away from education and shared decision-making, which is how we are able to overcome much of the hesitancy today. Mandating vaccine may further alienate and damage relationships in areas of the country that have disenfranchised populations historically. And I might add, with the politicization of this particular vaccine, it's going to potentially alienate and damage other populations as well, not solely those who have been disenfranchised historically. So how do we think about this? Because it seems to me that this is something that needs to be balanced with our desire to have a safe environment for these patients. No, nobody wants to tackle this.
I'd like to answer, but not necessarily first, but I'll give it a shot. This is an area where I would really like to see empirical research. I think we speculate a lot about this. So I love that it asks, do we actually have a sense of what the rate is? And I think that would be a great thing to know about. At the same time, because of what I said about proportion dominance, even if the rate is low, if it's something where, especially for something like lung transplant, it makes a big difference to outcomes, it may still be relevant in terms of saving lives or other benefits. Even if it's not very many people on the wait list who are not vaccinated, say, if the delta between vaccine and non-vaccination for something like lung is really big, it may still be justifiable from a benefit and harm perspective. In terms of the alienation and the education concern, I would be really interested in the voices of the people who have been medical providers about this. It may be that it's not so much having the requirement may have competition with education, but how the requirement is framed and whether it's accompanied by efforts to improve access, education. It may be not requirement or not, but how the requirement is designed. In terms of alienation and politicization, I think one concern I have about the objection that we shouldn't consider vaccination status because it's politicized is that if vaccine requirements are not adopted, it doesn't seem to me that we can get away from politicization by not having a requirement. Once it's politicized, it doesn't seem to me that any way to go gets us out of that. The question is how you sort of explain and justify the requirement, and whether you can give reasons to people who are subject to the requirements that are ones that can be justifiable to them. I think, especially when I look at, with the Native American population that has been so highly vaccinated actually in many states, but also is hit hard by non-COVID conditions, I worry about, say, not mandating vaccine for some of those communities, alienating relationships with them. So I think it's an area where I agree that the politicization makes it really tough. I'm not sure it points us toward mandate versus not.
I'll add that experience with healthcare worker vaccination policies has taught us that mandates are the single most effective intervention to maximize vaccine uptake, at least for healthcare worker flu vaccination. And I realize it's a very different population, but our candidates do have a lot of interface with the healthcare system and do have a lot of opportunities to have their vaccination status assessed, to receive education or have vaccinations recommended to them. So it may be a reasonably close cousin population to us, and mandates may actually be the best intervention to increase vaccine uptake in the candidate community as well.
The case studies that were presented suggested that non-vaccinated caregivers may be a serious risk to those who receive a transplant. So what are the ethical and legal possibilities to require them to get vaccinated so that they do not put the recipients in danger? Can this be a requirement for transplant that the caregivers get vaccinated? And I think it is at some institutions. Or is it a matter of just strongly recommending that caregivers get vaccinated? Are there thoughts on what the policy should be or can be? I think there's probably both a legal question and an ethical question here.
And this is Deb. I presented the cases, and we can't even really require mandates yet for our recipients that are awaiting transplant. We do strongly encourage, and I agree with Dr. Kumar that informed decision making is key. But I think sometimes that's a step removed from getting the patient transplanted, and it's just not in their forefront, because we are actually running into more problems with caregivers not being vaccinated than the potential recipients. So we did have one case, though he was intending to get vaccinated, it just hadn't happened yet. And again, this is California, so we've got a pretty high vaccination rate, at least in the Bay Area. So I would love to see mandated vaccines, but I don't think we'll be able to do it.
Legally, I actually think this is just an instance of the general issue of social support requirements. I'm not sure there's anything special to requiring vaccine actually for caregivers. The question is just whether it's practicable and whether there are others who have raised equity concerns about any sort of social support requirements. So I'm not sure there's something unique about this one, but I think it's like many others.
And I think we may have time for one more question. Benjamin Hippen wants to build off what Dr. Persad talked about with regard to, I just lost that from my screen. With regard to the question, I don't know where it went, but the question was related to directed donation. And
sorry, I was trying to answer it by typing, Doug.
Oh, okay.
Caused it to disappear.
So I think, go ahead.
My answer is just that I'm not familiar with the OPTN rule against directing to groups. I do think, as I said on the slides, there's a difference between directing on the basis of a protected class identity, like race or sex, and directing on the basis of a class defined by a choice. But I don't know of other examples where people have said, can you donate to somebody who was in a tragedy or military, or to people with a rare pediatric disease or something? I don't know whether that's done. And if it's not done, maybe it's a general rule.
But I think, to get at, I think the intent behind this question, would it be possible for somebody to do a directed donation with the caveat? I mean, in other words, the direction is only to somebody who's been vaccinated, or only to somebody who's not been vaccinated. And I could see either scenario from a potential donor.
I think it would be logistically difficult. The only way that I could imagine this happening would be if donations were expected to happen in centers with mandates in place. I don't think that you could actually make this demand as a donor or donor family at the point of procurement. This is made logistically more difficult by the really diverse center policies and then by the really far range over which we distribute and allocate organs these days. So I'm not sure that it's technically possible.
Any final comments our panelists want to make? I think we have come to the end of our time. This has been, I think, a really stimulating discussion, and hopefully gives our audience members some things to think about as they go back to their own work and work with their own institutions and struggling with what I think are some really difficult issues. So thanks again to our panelists, and thanks to the American Society of Transplantation for your support of this webinar, and enjoy the rest of the day.
Thank you so much. On behalf of the Psychosocial and Ethics COP, I'd like to thank all of our panelists today for today's session, and thank you to all the attendees for joining with us. Please remember to complete the evaluation survey. We will also be posting the recording to the Psychosocial and Ethics COP Hub. Thank you again.